Sorry, I got a phone call that interrupted the recording. The dogs also get retinitis pigmentosum. What we noticed with her was that she started bumping into things specifically and only at night, and she had a hard time finding the tennis ball if it wasn't right in front of her face. And that actually perfectly matches up with the clinical presentation for retinitis pigmentosum. You lose the peripheral vision, but the central vision is fine, and because of loss of rods, which are easily activated by just a tiny amount of light, you really can't see at night. So we got to have all the lights on, and you got to put the ball right in front of her face, and she can actually see completely fine if you do that. Because we have this degeneration, you get on the fundoscopic exam, you get these bone spicule deposits over here. And if you'll notice, this is on the periphery, right? Here we have the optic disc and then the macula and whatnot, but it's on the periphery where we're losing most of the things. Eventually, it will progress to get the cones, but initially just the rods. Pretty much the opposite of this, age-related macular degeneration. Remember that the macula is central vision. Now, usually this is not going to be due to an infarction because of the dual blood supply, the PCA and the MCA. But just as people get older, it's age-related. It's the biggest risk factor. You get this natural buildup of drusen, which is like a cellular debris, fats, proteins that are going to leak out of the vessels and build up. And they're going to ask this. It builds up between the retinal pigment epithelium and Bruch's membrane, which again are sandwiched in between the retina and the choroid, which has the vasculature. This can also just lead to edema if we're pushing too much stuff out. The osmotic pull might pull fluid out. And this is one of three ways that we can cause retinal detachment, the exudative mechanism. So loss of central vision is sometimes it's mentioned as a scotoma. And there's two types: dry, which is 80%. This is just where we have a buildup of drusen, and then wet, which is 20%. Here we can see all of these little, drusen over here. And here in the center, you can see that we have a little bit of macular edema. And so here we're losing our vision in the center, and also notice that we're losing the color as well. And that's because the central vision with the macular fovea is the cone. So you lose central vision, but you also lose the color there as well. So wet versus dry. Dry is just this buildup of drusen. Again, here's our retina, here's our choroid layer, here's our RPE, and here's Bruch's membrane. And it's going to build up between Bruch's membrane and the retinal pigment epithelial cells. This can progress to wet if there is extra VEGF and we have abnormal growth of blood vessels. This can cause hemorrhage and edema, and this is a little bit more of a medical emergency here. We have hemorrhage and more severe edema in this case. Diabetic retinopathy, so similar to like dry versus wet for AMD, we're also going to have a dry versus wet for diabetic retinopathy. A couple things to look for is we're going to have these aneurysms. Aneurysms lead to hemorrhages. We're going to have ischemia. This is infarction of nerves. We get these cotton wool spots. And if you have the worst type, there's non-proliferative, which is kind of like dry, and then proliferative, which is kind of like wet. You're going to have this abnormal growth of blood vessels. Hard exudates because kind of like drusen, we're pushing out like cellular debris, fats, proteins, and whatnot. So diabetes in general is a silent killer, and this is no exception for the diabetic retinopathy. It might progress for 15 or 20 years before some even knows that they have a symptom. So people are asymptomatic for a long time, and so we can diagnose this based on pathological findings. So the pathophysiology, the progression of this is that hyperglycemia is going to damage pericytes. Pericytes take up too much glucose. Aldose reductase converts this into sorbitol. Sorbitol is very osmotically active. It's going to pull a lot of water in. It's going to kill these pericytes. You can only detect this under a microscope. So, if someone has, early stage diabetes, they've had it for 5 or 6 years, they come in, you actually, in a fundoscopic exam, you probably won't see anything, right? Because it's difficult. You'd have to take a biopsy and look at the pericytes, which is quite difficult. So no clinical presentation at this stage. But over time, we're going to damage these pericytes. Advanced glycation end products are going to stick into the vessels and damage them and maybe cause atherosclerosis. And so we're over time going to weaken the vessel walls, which is going to increase the permeability and the susceptibility to aneurysms. And it's also going to cause unregulated blood flow as we damage these like precapillary sphincters, which is pericytes are helping regulate the blood flow. So All of this leads to, as we said, weakened walls, which leads to aneurysms. Proteins and lipids are now going to leak out of these extra permeable capillaries. And this can be trapped in the retinal tissue. So we see this hard exudate like the drusen. These are the white flecks that we see. Fluid leaking out can lead to edema. And specifically, if it leaks out of the macula, this is actually the main cause of blindness in people with diabetic retinopathy, is damage to the macula via the edema. And as we mentioned, this is a loss of central vision, a scotoma. Unregulated blood flow can, if we don't get enough blood flow to the nerves, can cause an infarct. Nerves are always extra susceptible because they don't have any glycogen, and they just have such high energy demand. So this is known as a cotton wool spot. And we kind of see this here. And the aneurysms, we can kind of see, maybe you can't see it in this picture, but the aneurysms, you can see a little bit under. Do we have any here? Yeah, here's an aneurysm. The aneurysms actually look very similar to the hemorrhages, and one follows the other, so it kind of makes sense that they do. So we have these cotton wool spots, we have these aneurysms, we have the hemorrhages, and then we have the drusen, all pathological findings. But the vascular proliferation, remember, this is the analogous to the wet macular degeneration. This is a compensatory mechanism where we don't have enough blood flow, so our body's thinking, hey, well, we should just grow extra blood vessels. But this is actually bad. These blood vessels are abnormal, and they don't really get the job done, and they can lead to tractional retinal detachment. This is the second of our three causes of retinal detachment. This is proliferative retinopathy when we have this vascular proliferation, and this is a medical emergency. So here we can see these, extra growth of blood vessels. This is probably a little bit more severe than it would normally look. Really what you get, and they'll describe this as tortuous. They're all twisted up on themselves. And it kind of reminds me of when I fly home to Florida and I'm looking over at, all our swamps and marshes and the Everglades and whatnot. And these blood vessels kind of look like the tortuous blood vessels during proliferative diabetic retinopathy, which is, again, medical emergency, late stages. More generally, we're going to see these hard exudates, the proteins and the lipids being pushed out of the leaky capillaries. We can see microaneurysms. Notice they say microaneurysm or hemorrhage. They're really hard to tell, but you just see these little red dots. And the hard exudates, which I guess we talked about. And here we can see a little bit of these tortuous blood vessels. Here we go. Here we have a cotton wool spot, which is a nerve infarct. Hypertensive retinopathy, very, very, very similar to non-proliferative diabetic retinopathy. The two differences is difference number one is we have AV nicking, and difference number two is we have papilledema. So what is AV nicking? So this is arteriovenous crossing. So here we have an artery. Remember, these are more translucent, a little bit smaller, and it's running on top of our vein right there. But because it's normal artery, it just kind of lightly pushes on the vein, and the vein is fine. But in the second picture, in B here we're going to have hypertension. So here I'm going to have an artery, and you can actually see it's a little more thick and a little bit more full, and that's because there's more blood in it, there's more pressure. And so when it moves over our vein, moving up here, notice it compresses the vein, and we get this kind of like hourglass. So the vein is very thick here, and then it kind of like goes in a little bit, goes in, and then it goes out again. So you get this kind of like hourglass shape where you're compressing the vein. And it makes sense. Veins are a little bit more pliable, and arteries are less pliable. And especially if your artery is filled with too much fluid, too much pressure, it can push down and cause this appearance. And papilledema is just, if you have hypertension, elevated intracranial pressure, this can cause papilledema, which is the blurred margins of your optic disc where you have an enlarged blind spot. And really, let's just underscore the major differences. This is our normal optic nerve. Here we're going to have our cup. Here we're going to have our disc. In glaucoma, we have too much intraocular pressure, and that causes this cupping, where the radius of the cup becomes too large relative to the radius of the overall disc. So this central circular bright spot is going to enlarge. So intraocular pressure, this is narrow open angle, too much fluid produced, trabecular meshwork resistance, or you have the pupil dilation causes narrow angle closure. And papilledema, intracranial pressure is up, so this is the opposite here. Tumors, brain bleeds, hydrocephalus, bunch of different causes, and the entire optic disc it swells on the one hand, kind of looks like the Eye of Sauron, but it blurs. The margins become blurry. Is I think for me easier to see. But there's no retinal cells here, so if you have a large optic disc, we're going to have a larger blind spot. Retinal detachment. So we've talked about 2 out of the 3 ways retinal detachment can happen. This is exactly what it sounds like. The retina is going to peel off. So, here's our retina. It's attached, and it's peeling off. And there's a couple different ways it can happen. One of them involves a retinal tear. That's the third way, which we'll get to in a bit. But imagine if the retina is being peeled off. Well, you're probably stimulating the retina if there's enough force to peel it off. And so stimulation of the retina causes these little flashes. So I would know that photopsia, seeing little flashes, might be a precursor to retinal detachment. So here's our retinal layer, and here's the RPE, and here's the Bruch's membrane, and here's the choroid. If you separate the retina from the choroid, there's no supply of nutrients. So this is a medical emergency. These cells are going to die very quickly if you have a retinal detachment. Here's normal vision. And if the retina is, like folding in on itself, you can literally actually see this is the retina folding over itself like a piece of paper. And so people describe it as it looks like the curtain's being drawn over their vision. This is the retina. And this might be completely dark, folding downwards. What are all these little spots, these little floaters and whatnot? Well, if you pull the retina down, a bunch of, cellular debris and crap is going to probably litter the eye. And so that's just going to be picked up. It's going to cast these shadows on the functional retina that still exists, causing all of these little blots. A big risk factor for retinal detachment is myopia. And why myopia? Well, myopia, one of the risk factors for that, the risk factor is that we might, you could have a high refractive index, but maybe you have an elongated eye in the anterior posterior axis. And so here, let's say that this is our retina right here. That's a normal retina. But let's say that if you have a long eye, it's not necessarily that you have more retina. You have the same amount of retinal tissue, but it now has to be stretched because your eye is so long. And if you stretch this retina, you make it thinner and it's more susceptible to tears. Which leads us to our 3 things. So tractional retinal detachment. So proliferative diabetic retinopathy is this neovascularization is actually going to form a little scar tissue, and the vitreous humor over here is going to pull on the scar tissue. It's going to pull it inwards for whatever reason. I don't know why, and it might pull the retina apart. Exudative is the buildup of drusen that we have and macular degeneration. Is going to be osmotic. It's going to pull in fluid, or maybe there's just trauma and more fluids getting in the subretinal layer for whatever reason. All of this fluid in the subretinal layer can just push it outwards, and so that's exudative. And then the third one is regmatogenesis retinal detachment. This is the most common mechanism, and we'll go into more detail talking about this now. So for whatever reason, I don't know why, your body just gets old and shitty, just entropy. The vitreous humor starts to break down. Lysosomes start to release their contents, and it just, there's liquefaction of the vitreous humor. And that forms these little pockets where, the vitreous humor should be jelly-like, but now it's kind of more liquidy. And this is going to cause shifts in pressure. Things are going to move around if you just now have these little pockets of liquid. And things are going to move around. And it might ultimately start pulling the vitreous humor away from the retina over there. And we can kind of see this here. So the vitreous humor is being liquefied, and that causes all of these weird pressure pockets, and it starts tugging where the vitreous humor is attached to the retina. And some of the retinal tissue might float away over here like this. If we tug too hard, it might actually detach the entire vitreous from the retina. So if we look just more at this first case, the vitreous being tugged at and little parts of it breaking off, we call these floaters. We see these little floaters over here, and that's, again, just them casting shadows on the actual functional retina. And so the same way that a TIA, angina might tell you that you're about to have a heart attack. TIA that might tell you you're about to have a big stroke. And if you see a lot of floaters or photopsia, that's telling you that the vitreous humor or the retina is being damaged in some way, and maybe a retinal detachment is incoming, and so you can prepare. And all right, so just to follow the whole thing, liquefaction can lead to little pockets, which leads to vitreous tugging and detachment from the retina. Anytime you're tugging at the retina, this can cause stuff to break off. You get floaters. Pulling at the retina can stimulate it, causing little light flashes, photopsia. And this plugging at the retina can cause a retinal tear. If you have a retinal tear, fluid can rush in. And similar to what we saw with the exudative, a buildup of fluid under the retina. So you can actually see this picture here. Buildup of fluid in here can actually push at the retina, so that the fluid rushing in the subretinal area pushes the retina out, and that is what causes the detachment. And this is going to be even more photopsia, and this is now where we have the curtain coming down. Retinoblastoma, R for retina, B for bone. We have this normal red reflex when we take a picture, the light comes in and it bounces off the eye. That's normal. But if you've got a big tumor, the light comes in and it bounces off. It just has a different, refractive index or different, chromophores, or I'm not even sure why, but maybe it's just the tumor itself. It's just this color. You lose the red reflex, something called leukocoria, leuco-white. So you get this white reflex, and this is a retinoblastoma. Retinal artery occlusion, remember that off the carotid, we have a small little ophthalmic artery which leads to the retinal artery, and what could cause a thrombus or to form, or I guess atherosclerosis. That's going to be the big risk factor here. But you could also have an embolus coming from the heart if you have atrial fibrillation, or maybe you have like infective endocarditis, or you have a PFO. So that way a deep vein thrombosis can actually cross from the right atrium to the left atrium and make its way up to the brain. And what you get is this cherry red spot. So notice that you also get this with Tay-Sachs or Niemann-Pick's, which are lysosomal storage diseases. Those, you're going to see that in kids though. So this will be in adults. If you have occlusion downstream or upstream, that means we're going to have ischemia here and here and here. For whatever reason, ischemia causes this little cherry red spot in ways that I don't understand. What's easier to understand, though, is that we get this particularly pale retina, which is always associated with ischemia. Retinal vein occlusion, so opposite end, here's our retinal vein. This could be from atherosclerosis, causing AV nicking, right? The hypertensive retinopathy, the too much blood in the arteries can compress the veins, causing this little hourglass look. So it doesn't necessarily have to be a clot, but if you have obstruction of outflow, too much is going to build up and it's going to push out, and this can cause edema or a hemorrhage. So that's if you have it in a smaller retinal vein. If you have it in a larger, like the central retinal vein, this is probably because you have some like hypercoagulable state. You've got someone who's like a Leiden mutation, or they're on oral contraceptive pills, or they have cancer. And so this is a thrombus disorder. And here we're going to have a much larger hemorrhage, maybe hemorrhages in many different locations.